And welcome to today's Guidelines of Care for the Management of Psoriasis with Systemic Non-Biologic Therapies webinar. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we begin, I'd like to acknowledge our sponsors, Bausch Health Foundation, Celgene, and Novartis, for their support of the Psoriasis Guidelines webinar series, of which this webinar is part of. To help guide you on how to participate in today's event, we've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane, and the dial-in information will be displayed. You'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, dermatologist and rheumatologist, Dr. Alice Gottlieb. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served the more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan on July 1st, 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over the next 5 years, NPF will focus on achieving 3 goals: to lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes: to date, NPF has funded over $24 million in grants and fellowships. That includes $3.7 million in grant and fellowship funding announced this summer. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged us to define prevention to better guide the proposal development. And that's how it expanded to disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the United States. The registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 11,915 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are? Ask. If they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or good taint psoriasis, and be a candidate for office or home phototherapy. There's no washout of topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you as a patient answer survey questions, which you and researchers can analyze for trends and new insight. Citizen Scientist is currently being revitalized for greater community benefit. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we'd appreciate you sharing your experiences with us. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis, Walk, or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar. Well, you'll learn more about the AAD-NPF Guidelines of Care for the Management and Treatment of Psoriasis with Systemic Non-Biologic Therapies, how the guidelines offer evidence about the efficacy, risks, and benefits for use of such treatments for psoriatic disease, impact of such guidelines on discussion with your healthcare provider, resources to help gain a better understanding of psoriatic disease and available treatment options. Now I'd like to introduce you to our speaker, world-renowned dermatologist and rheumatologist, Dr. Alice Gottlieb. Dr. Gottlieb is a clinical professor and medical director with the Department of Dermatology and Department of Medicine at Icahn School of Medicine at Mount Sinai, Beth Israel in New York. Dr. Gottlieb is known for making significant strides in the scientific fields of dermatology and rheumatology that have led to a greater understanding of the disease and developments of novel treatments. She is internationally recognized expert in the field of psoriasis and psoriatic arthritis. Dr. Gottlieb is one of the first scientists to demonstrate that psoriasis is a T-cell mediated disease. Her research uses targeted immunobiologics as pathogenic probes, providing new understanding of the pathogenesis of psoriasis and providing the foundation for biologic drug development in psoriasis and psoriatic arthritis. Dr. Gottlieb was the first to show the efficacy of TNF blockers as monotherapy for moderate to severe psoriasis. Her research led to multiple TNF blockers being FDA approved for psoriasis, which revolutionized the care of psoriasis and psoriatic arthritis patients. Her research has affected drug development in psoriasis, psoriatic arthritis, rheumatoid arthritis, inflammatory bowel disease, and transplantation. And she continues to be involved in innovative clinical research at Mount Sinai. Dr. Gottlieb is one of a handful of doctors in the U.S. that are triple board certified in dermatology, rheumatology, and internal medicine. She is also the recipient of numerous awards for her excellence in teaching medical students, for her mentorship in bench and clinical research. She is a past member of the Board of Directors of the American Academy of Dermatology and holds the distinction of being an honorary member of the American Dermatologic Association. In 2018, she was honored with an award from the National Psoriasis Foundation in recognition of her leadership in psoriasis and psoriatic arthritis research and care. She continues to be a President's Council member of the National Psoriasis Foundation. It is truly my honor to welcome Dr. Alice Gottlieb, who will present today's webinar, Guidelines of Care for the Management of Psoriasis with Systemic Non-Biologic Therapies. Please welcome Dr. Gottlieb.
Well, good evening, everybody. I'm delighted to be part of this initiative, and I've been a member of the National Psoriasis Foundation for many, many decades. And my mother, who passed away this spring, but she had psoriasis and psoriatic arthritis, and she too was a member of the National Psoriasis Foundation. Here are my disclosures. I'm actually grateful to all these companies because they're giving us the drugs that are changing people's lives. So this paper that we are giving this talk on is really kind of a how-to manual for doctors to use pills that are FDA approved for psoriasis. So some of this will be kind of dry, and I'm going to skip over it, but you'll have it if you want to refer to details. So we have 4 oral medications that are FDA approved for psoriasis: methotrexate, cyclosporin, acitretin, and apremilast. Let's talk about methotrexate. How does methotrexate work? Well, it inhibits nucleic acid synthesis. Nucleic acids are the building blocks of our genetic material. Through another mechanism, it causes the increase in a molecule called adenosine inside the cell, and that is an anti-inflammatory molecule. The primary effect of low doses less than 25 milligrams is to decrease the proliferation of white blood cells. not to actually decrease the proliferation of keratinocytes, the major skin cells in our epidermis. I think many people in this audience probably have been dosed with methotrexate, but I'll tell you how it's done. It's a once weekly dose. You don't have to divide it into 3 doses. It usually ranges from as little as 1 pill, 2.5 milligram, up to 10 pills, which is 25 milligrams. It can be delivered actually oral by subcutaneous injection. And if one is short on the pills, there was a shortage a few years ago, you can actually drink the IV solution. I'll tell you about that later. There are situations that you have to adjust the dose and use lower doses, like if you have decreased kidney function. There are drug interactions I'll go over with you later. There are certain disease states which make it unattractive to use methotrexate, such as diabetes, obesity, liver disease. So how we usually do it is one starts with what I call a baby dose, 1 pill or 2 pills, and then you look at a blood count and liver test, but the blood count is the most important, 5 to 7 days later. And the side effect of methotrexate that's the most dreaded is bone marrow suppression. And that's really what you're looking for when you give a test dose and 5 to 7 days later measure the effect. In general, one adjusts the dose to achieve optimal skin clearance while avoiding adverse events. And methotrexate is not a fast-acting drug, so it takes about 1 or 2 months till you can actually show an effect. So as I told you, there are doses. There's pills, there's subcutaneous, which is used in 2 situations, maybe 3. One of the major or most common side effects of methotrexate, it makes you have an upset stomach, it can make you nauseous. And so there are fewer gastrointestinal side effects if one uses subcutaneous dosing. It's also useful for the patient who cannot self-dose, or for the unreliable patient where the doctor doses and wants to control what's going on. There is an IV formulation, which is 25 milligrams per milliliter, and 0.6 milliliters is equal to like 15 milligrams, or which is equivalent to 6 2.5 milligram pill tablets. The availability of the IV is roughly equal to the oral, so that one can drink the IV solution instead of buying the oral pills. It's often cheaper than the oral methotrexate, and as I mentioned before, there was a time when you could not get methotrexate pills, but the IV solution was available. What about folic acid supplementation? Folic acid is usually given by prescription, a 1 milligram pill daily, except on the day when methotrexate is given. And the rationale is to lower liver and gastrointestinal toxicity and maybe bone marrow toxicity. Methotrexate is what's called a folate antagonist by its mechanism. So if you give folate, are you subverting the effects of methotrexate? The question is, we don't really know. Whether folate administration actually decreases methotrexate efficacy is unclear because each study is variable and you can't just pool them together and say that the combined evidence shows one way or the other. But I do give folate supplementation when I give methotrexate. Now, methotrexate is, I have to say, not a slam bang terrific drug for psoriasis. This was a clinical trial, placebo-controlled, double-blind, randomized, comparing placebo, methotrexate, and an anti-TNF called adalimumab. And the primary endpoint was a 75% improvement in PASI at 16 weeks. And how I call a PASI 75, this is more understandable for the ladies, but the men can use their imagination. I tell patients that achieving a PASI 75 means you can run around in a one-piece swimsuit and nobody knows you have psoriasis. Achieving a 90% improvement means you can run around in a bikini and nobody knows you have psoriasis. And a PASI 100 means you can run around naked and no one knows you have psoriasis. So if you look at the actual numbers, you can see that this placebo effect was quite high. 20% is very high for a psoriasis study. Adalimumab, this anti-TNF, is about 80%. Methotrexate is only 35%. So I do not think that methotrexate is a highly efficacious drug in psoriasis. There are combination studies that have shown safe use with tumor necrosis factor blockers, especially in psoriatic arthritis, and it can be used with narrowband ultraviolet B therapy. Now, this is focused on psoriasis with regard to psoriatic arthritis. I think studies are fairly clear. It can control signs and symptoms of psoriatic arthritis, but it is definitely unclear if there's any inhibition of radiographic progression. Now let's get to toxicity. There is plenty with methotrexate, and I'm sure in the audience, some people have experienced some of these. Early on, nausea, loss of appetite, feeling just very tired, sores in the mouth are not an uncommon side effect from methotrexate. As I mentioned, using subcutaneous or intramuscular dosing may help. Taking methotrexate with food may help. Some very serious side effects include immunosuppression with increased infections, tuberculosis reactivation, increased lymphomas. There's a black box warning in the package insert for methotrexate for lymphomas. In the rheumatoid arthritis population, inflammation of the lung can be a side effect. And what is definitely a side effect, and almost any doctor who treats enough patients gets a scary episode of this, and that's bone marrow suppression, which means that your platelet count or your red cell count or your white cell count can drop down to dangerous levels. What are risk factors for that? Increased age, dosing mistakes, drug interactions, low albumin because this drug methotrexate sticks to albumin in the blood, alcohol use and especially alcohol overuse is a risk factor. Now, methotrexate is absolutely not to be used in pregnant or nursing women. Methotrexate is an abortifactant. It causes birth defects, decreases sperm count, and it can be detected in human milk. So if you're nursing and you're taking methotrexate, the baby will get it. And that's not a good idea. Liver toxicity is a big side effect with chronic use. People's livers can get cirrhotic and they will need a liver transplant. And the earliest liver transplants were done in people who had too much methotrexate. So what are the contraindications? That means absolute no-nos. You cannot take methotrexate if you're pregnant, nursing, if you overuse alcohol, chronic liver disease, if you have immune deficiency to begin with, if your bone marrow has low elements to begin with, and obviously if you're allergic to methotrexate. There are drug interactions, and a common one is Bactrim, which is an antibiotic, which has it's a combination of two drugs, and one of them kind of has methotrexate-like activity. So if you take Bactrim with methotrexate, you're effectively taking more methotrexate, and the side effect you'll see is bone marrow suppression, and that can be very scary. Another situation is, especially in the psoriatic arthritis population, which takes a lot of non-steroidal anti-inflammatory drugs or aspirin. Non-steroidal inflammatories include things like ibuprofen, for example. Methotrexate is cleared by the kidney, and if you take a lot of these non-steroidal anti-inflammatory drugs, they can inhibit the elimination of methotrexate from the kidney. And if you take a lot of them, there has been reports of bone marrow suppression because the methotrexate level starts rising in the blood. This is unusual, and you have to take an awful lot of that to make that happen. There are other ones that I put here for your reference. If any of you are taking methotrexate in any one of these drugs, I suggest you talk to the doctor who prescribed the methotrexate and discuss with them. Relative contraindications are abnormal liver or kidney functions and an active serious infection. So what does the doctor do to monitor this? And I'm not going to go into that much detail on this because, as I said, this article was more a how-to handbook for doctors. What the doctor should be doing is taking good history and physical. They should be screening you against hepatitis B and C because you don't want liver disease and take this. Should be doing TB screening. Should obviously get blood counts and your liver tests and your kidney tests and pregnancy tests when it's relevant. And every time one increases the dose, at minimum, one should get a blood count 5 to 7 days later. Why 5 to 7 days later? What I always learned was that if you do a blood test, let's say 2 days after you take it, the liver test can be falsely high. And then that will make you not increase the dose when you should. But when you're in steady state, then you only have to do the blood count, the liver test, BUN creatinine, every 3 to 6 months. Pregnancy test needs to be done monthly, ideally. What are risk factors for damaging your liver? Obesity is one of them, diabetes, high lipids like cholesterol and triglycerides. Alcohol use, too much alcohol is not a good idea. If you have pre-existing liver disease, one of these is non-alcoholic steatohepatitis, often seen in heavy people, persistent elevated liver tests, hepatitis B or C, exposure to hepatotoxic chemicals. Some professions unfortunately have that. And in these settings, you should consider another therapy. So I'm leaving methotrexate, going to cyclosporin. Cyclosporin acts by blocking signaling that leads to the production of inflammatory molecules. And it does so because it binds to cyclophilin. That exact mechanism is not that important. It blocks pro-inflammatory signaling. What are contraindications to cyclosporin? If you've had a lot of PUVA, you shouldn't have it because both PUVA and cyclosporin are associated with increased incidences of squamous cell carcinomas. Cyclosporin is toxic to the kidney, and almost everybody gets kidney toxicity if they take it long enough. So if you start with abnormal kidney function or uncontrolled hypertension, you should not get this drug. You should not get it in the setting of malignancy. It was originally a transplant drug. It suppresses your immune system. It's not a good idea. Obviously, if you're allergic to it, you shouldn't take it. Like all drugs that modulate the immune system, live vaccines are to be avoided. If you have a major infection, it's not a good idea to give a powerful immunosuppressant, and poorly controlled diabetes is another reason. What's good about cyclosporin before we had the biologics is that it's great crisis treatment. Works well and it works fast, but limits its chronic use is toxicity, and you cannot use it really chronically. I like to start high and go down in dosing because by somebody's on taking cyclosporin, they're usually pretty desperate to clear up. If you do use cyclosporin, we have to take blood pressure, BN, creatinine, those are kidney tests. We have to take that at minimum once monthly, and you adjust the dose downward or stop if there's a problem with that. This drug interacts with a whole lot of other drugs. I mean, it's not just a little bit, it's, whole big thick books worth of drugs. And so, for instance, common drugs like the anti-cholesterol statins interact with cyclosporin, and you have to be careful, and you have to consider lowering the dose if patients are taking it. And many patients take statins, okay? There's a whole list of other drugs. I mean, erythromycins, certain oral antifungals. I mean, the list is very long. So when I have a patient on cyclosporin, I tell them, you have to tell whatever doctor wants to put you on any pill, you have to tell them that you're on cyclosporin. They should look up the drug interaction. So the monitoring is, there's certain blood tests and things listed here. One has to do it every other week initially to monitor, and then you can do it monthly. And there's an algorithm for adjusting the dose of cyclosporin based on your kidney tests and blood pressure. That's something your doctor has to worry about as a patient. Your doctor should be doing this for you. Now, the efficacy is very good. Now, the experiments done with cyclosporin were done before the rigorous kind of experiments we do with biologics. But at 5 milligram per kilogram per day, cyclosporin induced that PASI 75 rate, somewhere between 50 and 90%. I think it's frankly closer to the 50 to 60%. One problem with cyclosporin, and I tell patients this, that you'll love me when I put you on it, but it's like Cinderella at midnight. As soon as you stop it, within a month, you get a rapid relapse. And some people feel you can relapse to worse where you started. The hard part with cyclosporin is stopping it. You don't use it with phototherapy because they both, phototherapy, especially PUVA, and cyclosporin have increased squamous cell carcinomas. People have said you can use methotrexate and cyclosporin, but the only case I had of methotrexate-induced bone marrow failure was with a person where I did try it with cyclosporin. Creatinine was only slightly increased, and the patient came back with life-threatening low platelet levels. And so I will not use methotrexate and cyclosporin. Its efficacy is good in psoriasis and even in the life-threatening forms like erythrodermic and pustular psoriasis. It does not work well in psoriatic arthritis. There are no studies on inhibition of radiographic progression. I would not use cyclosporin in a patient with psoriatic arthritis. Toxicity, quite a bit. I would say that kidney toxicity, hypertension are the most likely and almost guaranteed toxicity. Neurologic is pretty common. About 10% of patients either get headache, tingling, tremors, seizures, fatigue. I had a patient fall off a ladder because of the cyclosporin. This is before the days of biologics. Immunosuppression, lymphoproliferative, meaning leukemias, lymphomas, squamous cell carcinomas, increased infection, other cancers. And here's a side effect that can be very bothersome to patient, excess hair growth. And it can be very bothersome. It's, of course, really bothersome to women. Now, the men who have male pattern baldness like it because their hair grows. And so as soon as you stop it, the hair falls out. Worsening acne is a problem. People can get excess overgrowth of gums, so they get these puffy, ugly-looking gums. Some people get nausea, vomiting, diarrhea, abdominal pain. Not so much, though. I have not observed much shortness of breath, cough, or increased runny nose. Blood tests, clearly, I mean, kidney tests can be abnormal. Your triglycerides, which is a kind of blood fat, can go up. Your magnesium level can go down. So this is a tough drug to use. Most of our data on cyclosporin in pregnancy and lactation, breastfeeding, comes from transplantation because that's where it was first discovered. So in the kidney transplant patients, it is associated with premature birth, low birth weight. It is not teratogenic. It does not cause birth defects. Mothers may have higher blood pressure, anemia, urinary tract infections. Preeclampsia is a form of hypertension. It does pass through breast milk, so I would not give it to a lactating mother. Now, this is why there's so many drug interactions with cyclosporin, literally a book's worth, because it's metabolized by a system called cytochrome P450. It's not important, the name. But many drugs are metabolized by the same system. And sometimes cyclosporin could cause increased levels of the drugs, and sometimes it could cause decreased levels of the drugs. So common drug interactions, statins, and how it will present is muscle aches, and at the very extreme, the muscles break down, and you can get breakup down in the muscle, and the products circulate in the blood and can cause kidney failure. So I have to check muscle enzymes when I have somebody on a statin and cyclosporin. Except for amlodipine, for the patients, I'll tell you that brand name is Norvasc. Almost all the calcium channel blockers interact. The erythromycins all interact. That's an antibiotic. Some of the antifungals orally interact. Many seizure medications interact. And grapefruit juice interacts. So I tell patients, give up grapefruit juice, which for me personally is not a big sacrifice. Other drug interactions, non-steroidals, so things like ibuprofen, same reason, they act on the kidney, and you don't want two things that can inhibit kidney function. There are certain classes of antibiotics, like gentamicin, they're called the aminoglycosides, that can have a problem. Potassium-sparing diuretics, like spironolactone, for example, can elevate potassium when used with cyclosporin. Thiazide diuretics, like hydrochlorothiazide, can cause increased kidney toxicity. Increased excessive alcohol use increases the levels of cyclosporin, which you do not want. And I am quite sure that the immunosuppressive properties of cyclosporin make vaccines less effective, and you definitely cannot have live vaccines with cyclosporin. I am now leaving that to acitretin. Acitretin, as I tell my patient, it's an oral retinoid, which means it's a distant relative of high-dose vitamin A. Its mechanism of action is really not known. It does modulate skin cell differentiation. So what the patient might notice is those thick mica-like scales become powdery and fall off. It thins the epidermis. It is not anti-inflammatory. It is not immunosuppressive, which does mean it's useful in situations where you don't want an immunosuppressive, but it also means as a single agent, it's not very effective for the plaque type cases. Its dosing is 10 to 50 milligrams a day once with the main meal. However, at the doses of somewhere like 40 and 50, patients are going to start losing hair, and they don't like it. And they're also going to get very dry, cracked skin. So I usually start with 25 milligrams once daily. You take it with the main meal because fat increases the absorption of the drug, so you get more bang for your buck. Dosing really is dependent on balancing efficacy with tolerability. But when I use acitretin as a mono treatment for regular plaque psoriasis, I do not tell patients they're clear because they almost never clear completely. Okay, I already mentioned that. These studies are not of nearly the quality that we have now. In one study, 23% of patients achieved with very high dose acitretin, where they're going to be very symptomatic, achieved a PASI 75 after 8 weeks. It does not work in psoriatic arthritis, as it causes excess bone formation around the vertebrae, which is called dish syndrome. So it can give people pains that are confused with psoriatic arthritis. Do not use it as a monotherapy in psoriatic arthritis. Drug interaction, this one is not so terrible. I do not think that, I think that's more theoretical, that acitretin can interact with cyclosporin. I actually think it's one of the only safe combinations you can use. You should not be using vitamin A supplementation because you don't want to get hypervitaminosis A. And I'll leave it at that for now. That's not the real problem with acitretin. Acitretin is a teratogen. It causes birth defects. It causes every bit as much as Accutane does. And the problem with it, that can hang around in the body for a long time, and in the presence of alcohol, it can present for a really long time. So I'm very careful about giving it in somebody who is of childbearing potential. So you have to do, obviously, a history and physical. Acitretin, the one lab test in the blood that can go up is the triglyceride, that blood fat. You do need to do a fasting a lipid panel. Liver tests, kidney function, I don't think is that important. Pregnancy testing, a must in the relevant population. And one monitors liver tests and fasting lipid profile every 3 months. Pregnancy, every month. But as I told you, I can't remember the last time I gave it to a woman of reproductive potential. It's useful in conditions where patients are immunocompromised. In olden days, HIV. Now that we control HIV, and I've used biologics in HIV-positive patients, I do not use methotrexate or cyclosporin. There are other reasons for immunocompromise where acitretin might be a good choice. Erythrodermic and generalized pustular psoriasis and palmar-plantar psoriasis do respond quite nicely to acitretin, so that's a good use. Acitretin is very useful in combination with either narrowband UVB or PUVA because it thins the epidermis, which allows the light to penetrate more, and you have more of the anti-inflammatory and skin thinning effects. It can be used safely in combination with biologics too. And as I mentioned, acitretin works quite well in combination with phototherapy. Use of acitretin decreases the total dose, the frequency, duration of phototherapy, limits long-term side effects, and can be more cost-effective for the patient because the patient pays every time they go to get a phototherapy, they pay a pretty hefty copay. So if you need fewer treatments, your costs will go down. Other use of concomitant acitretin with PUVA lowers the total UVA dose used, and there have been studies compared with PUVA alone. There are fewer squamous cell carcinomas when you combine with acitretin. Safety, number one, bad safety is teratogenicity. Birth defects, it's a bad actor. Don't use when patients are nursing. You have to wait, women of reproductive potential have to wait 3 years after stopping acitretin before they can conceive. The reason you want to avoid alcohol is that acitretin will back convert chemically to a long-acting retinoid called etretinate, which is why there's that 3-year post-treatment contraception requirement. Common side effects, which you'll almost guaranteed see, is dry skin, dry eyes, dry nasal mucosa, which can lead to nosebleeds. Cheilitis, which is in drying and cracking of the lips. Is when you're in therapeutic range for the psoriasis, you can almost guarantee you're going to get that side effect. Brittle nails, hair loss can be a problem, itching, burning skin. There's something called retinoid dermatitis where you get scaly red plaques with cracks in the skin superficially. Around the nails, you can get bloody growths called pyogenic granulomas. Hyperlipidemia, especially hypertriglyceridemia, that can actually lead to pancreatitis, which is a very painful inflammation of the pancreas. It can be seen with acitretin. I have literally drawn the blood of patients in acitretin where the blood is white and milky because of all the triglycerides. And it can cause elevated liver tests. To me, that's not much of a problem with acitretin. You cannot take acitretin with the tetracycline class of antibiotics. That's minocycline, tetracycline, doxycycline, because you'll get the worst headache of your life. It's called pseudotumor cerebri. Some people report mood changes, decreased night and color vision, aches and pains. I already told you about this dish syndrome where you get bony growths in the spinal vertebra with acitretin. And you should not use this in children because unless you really have to, because it can cause premature closure of the growth plates in bone. Now we have apremilast. Apremilast inhibits something called phosphodiesterase 4, leads to increased levels of something called cycloadenosine monophosphate, which leads to downregulation of molecules thought to be causing psoriasis. And one gives it in baby doses and then gets to a maintenance dose of 30 milligrams twice a day because there are GI, diarrhea, nausea, and also headaches and neurologic side effects. So one wants to start slow and work up to the maintenance dosing. Efficacy is not great. It's about a third of patients get that PASI 75. Psoriatic arthritis, very modest efficacy, never studied for inhibition of radiographic progression. Contraindications, supposed to adjust, there's not many, you're supposed to adjust downwards in kidney disease. Safety in pregnancy is unknown, don't give it. In a dehydrated patient, the stomach side effects like diarrhea, can be more severe and result in hospitalization. It's not advised to be used with strong inducers of that cytochrome P450 pathway, and those include rifampin and seizure medications like phenobarbital, carbamazepam, and phenytoin. Safety, the main side effects are diarrhea and nausea. It usually occurs in the first 2 weeks, many resolving after 1 month. Can be moderate and severe in intensity. Depression in 1% of population, I'd be careful about using it in a depressed person. I did have a patient who had intolerable night terrors and nightmares on apremilast. People get a 5 to 10% decrease in body weight, which is desirable. Headache is a problem. Cold. There's no blood monitoring requirement, which makes it convenient, which is why it's very popular with doctors, even though it doesn't work that well and it's expensive. I'm not going to talk about non-FDA approved drugs, but here are some that were covered in the article. Tofacitinib, fumaric acid esters, which are available really in Europe only. Hydroxyurea, mycophenolate mofetil, azathioprine, leflunomide, tacrolimus, and thioguanine. Most of these drugs are approved in transplant or in cancer or in rheumatoid arthritis. These are not FDA approved in psoriasis, and I rarely use them for psoriasis. The AAD-NPF guidelines for the management and treatment of psoriasis. So this was released about almost 2 years ago now, and it says that you have to consider the whole disease and the whole patient. Every patient at every visit, even if they have mild skin disease, needs to be asked about psoriatic arthritis because the delay costs joints. And so to me, that's number one. But you also have to ask about mental health, quality of life, how are they feeling? I can tell you I've had 6-foot-tall bikers break down and sob in my office talking about their disease. And when I clear it, they give me big hugs. And then they tease me because they know that I don't like motorcycles. But it does, if you don't ask, many patients, especially the men, will not volunteer. You have to ask. The guidelines give instructions on how to manage and treat patients with biologics, phototherapy, how to treat kids, patients with systemic non-biologics, and now I think this is the most recent one, proper use of creams and ointments and foams and spritzes. And there's a how-to for each one of those. So what do these guidelines mean for you? Provide guidelines based on current evidence, identifies guidelines for most specific examples, defines the role of the dermatologist, and I couldn't emphasize more how important it is for dermatologists to consider their whole patient and not just focus on the skin. Emphasizes the value of education. I tell my patients, go to www.psoriasis.org to get independent checking up about whether I'm telling you is right or wrong. And of course, the NPF is the partner with yourself and your healthcare provider in giving you optimal care. It's a little bit of a dry subject because it's a how-to manual, but I hope it wasn't boring for people.
No, I think you've provided a lot of information that is very helpful. So it's now time for our Q&A portion. If you have any additional questions based on what you've just heard, please submit them now through the questions panel on your attendee interface. We'll attempt to answer as many as possible in the time remaining.
Can I
Gottlieb,
please answer questions that are general? If it's about your specific condition, that I really would prefer not to do that.
yes. So the first question we'll ask is one that we received previously. You kind of alluded to this already. What bodily functions or systems do non-biologics affect to suppress plaque psoriasis?
So methotrexate suppresses the immune system, and so does cyclosporin. That's how they work. Acitretin mechanism is really not well understood, but it's felt to alter the development and differentiation of your skin cells, so that what you see in a patient being treated with acitretin is that they get these thick plate-like scales and they turn powdery and fall off, and the epidermis and the skin plaques thin, but you don't get the red out. You don't the inflammation it doesn't affect. So apremilast works by it's an immunosuppressant. It basically decreases levels of inflammatory molecules.
And what is the criteria for being a candidate to use oral non-biologics?
So I have to tell you that the biologics are far better. They're far better because they're safer. They can be used without having to stop because of toxicity or rotate because of fears of toxicity. They work better both in the skin and the joints. However, they are much more expensive than methotrexate, cyclosporin, or acitretin. So if I have my choice, I'd much rather use a biologic than any of these. Okay, so the situations where I mostly have to use these drugs is when the insurance tells you they will not approve a biologic unless you can show failure on at least one of these. That's the situation. And the other situation, unfortunately, and I've written an article on this actually, on what drugs to use in patients who have only Medicare insurance and simply can't afford expensive drugs. They can't afford apremilast either, by the way, but they can't afford the biologics and apremilast simply because Medicare, you have the donut hole, but it's more than that. Medicare, you pay a co-insurance, so you pay a percentage of the cost of the drug. And when the drug is, $70,000 a year or $50,000 a year, that's a sizable chunk. And the drug companies cannot give any support to either Medicaid or Medicare patients to help them pay for these biologics. So therefore, these are the patients where I'm forced to use orals, even when I know it's not the best treatment, because that's all they can afford. And it's a very unfortunate situation. Situations where I might use acitretin in a patient who has a solid tumor or something and wants to get their skin clear, it might be a situation I might use there. I think I kind of made my point, but I would never use methotrexate or cyclosporin as first line if I had to treat a psoriasis patient.
Okay, and I will mention that we do have a podcast on Medicare discussing the capping.
I'm glad the NPF has a session on it, but then right now I think that is the most disadvantaged population of my patients. Medicaid patients can get biologics. You might have to go through hoops, whatever, but they can get it. The Medicare patients, they can get the biologic, they can't afford it. And even the ones that are administered by a doctor or a healthcare provider, which goes under a medical benefit and not a pharmacy benefit, even then, they certainly in many places they get a facility fee and they still can't afford it. It's really a problem.
No, it is, and that's why we're working on this legislatively as well.
Oh, yes.
And another question is, can you talk about the role of JAK inhibitors?
There are no JAK inhibitors that are FDA approved for psoriasis. Tofacitinib is approved for psoriatic arthritis, and at the 5 milligram twice daily dose, that is the only FDA approved dose. And it doesn't work well in the skin. And by the way, it's in a very expensive drug too. But that's the only one that is FDA approved for psoriatic arthritis. There are no JAK inhibitors approved for psoriasis.
Here's another question. Is it a good idea to periodically change therapies? Does stopping and restarting a biologic reduce its effectiveness?
In general, it's not a good idea. Whenever they've done that kind of, and they do it for almost every biologic, continuous use leads to better outcomes than discontinuous use. And the other reason is that in some of the biologics, at least, that if you stop and start, the second time you do it, you have less of a chance of achieving an equal result to the first time you did it.
Moving back to systemic non-biologic therapies, someone has a comment that 4 treatments that you've mentioned or described sound horrible based on the side effects. Are there any safe options for plaque psoriasis?
Yes, and well, nothing is absolutely safe, right? I mean, but in terms of safety, this is one of the real advantages of the biologics. You can use them continuously and you don't have to stop them because of fear of side effects. They don't have drug interactions like what I've described with that. They don't hurt your kidneys, they don't hurt your liver, don't cause birth defects. So one of the big advances with biologics is that you can maintain people continually and safely on treatments without having to stop them or rotate them or yes. So that was one of the ways that biologics changed lives. I would say that, well, apremilast, there's no evidence that chronic use gives you cumulative side effects. It just doesn't work very well, and it's expensive. Methotrexate, cyclosporin, generally you cannot be on them forever. So those have to be rotated. Acitretin as a monotherapy is just not that effective. So most people don't stay on it because it doesn't work well long term. It doesn't work long, it doesn't work short term. It doesn't work that well to begin with. So now you can see I'm old enough to be pre-biologics. I'm nicknamed the Jewish mother of biologics because of the discoveries of the TNF blockers. The pills that are FDA approved are just not all that satisfactory. And biologics really change things.
Here's a couple questions that are similar. They want to know, should they be treating aggressively or not treat, and what is the impact of the disease?
This is what I say to all my patients. I'm a Jewish mother, so I can say this. I say, what's the difference between a Jewish mother and a Rottweiler? And the answer to that joke is that the Rottweiler lets go. And that's why I tell my patients, that's my attitude toward your psoriasis. My goal that I assume is that I want you to be clear, and I don't want you to have that. I don't want your joints to influence your daily activities at all. That's my goal. That is not every patient's goal. There are some patients who I know I can clear, but they only want, let's say, ointments and creams. And they might have extensive disease and they might be happy with a partial clearance. So ideally, my target is to aim for clearance and no active joint problems with psoriatic arthritis. But if the patient doesn't want to aim for that, doesn't want to go for that with treatment, they can do less if they're willing, if that makes them happy. I mean, so me personally, I always introduce the aggressive option, aiming for clearance. But some patients don't want it. They'd rather take a topical and live with the disease. My patients are my partners. I mean, I will say to somebody who has psoriatic arthritis and doesn't want to treat it, and especially if it's pretty obvious, I said, you really have to treat it. Please treat it, I mean, I start getting insistent, but I won't force them. Sometimes I'm really thwarted in Medicare. It's very frustrating. Obviously, then I would suggest clinical trials, which can be a lifesaver for people.
Right. Someone's talking about joint pain, and it's gotten worse with methotrexate. Is that common?
Methotrexate is not all that effective in psoriatic arthritis. In fact, there are 2 experiments. The one was called the MIPA study, where methotrexate failed against placebo, fake drug, in controlling signs and symptoms of psoriatic arthritis. There was another non-placebo controlled study that did show that methotrexate, it wasn't as good as etanercept, which is a TNF blocker, but that it did control signs and symptoms. But it doesn't do a great job. It really doesn't. And so if a patient is on only methotrexate and maybe some non-steroidal, and their psoriatic arthritis is not well controlled, they haven't begun to fight. We have 4 TNF blockers and 2 IL-17 blockers that not only control signs and symptoms, but inhibit radiographic progression, which means that this is a very strong statement. You can alter the natural history of psoriatic arthritis for the better. So patients who are only methotrexate, who have other options, haven't begun to fight. Now, unfortunately, there are patients who that's their only option because that's all that they can afford to do. And so if they can get in a clinical trial better, they do that then.
Right, definitely. And thank you, Dr. Gottlieb, for taking time to answer the many questions that we received today. Your expertise is greatly appreciated.
My pleasure. So good night, everybody, and have a good evening.
Thank you again. In addition to today's webinar, podcasts about the guidelines are also available as listed on the screen through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like more information about other treatment guidelines, you can catch Dr. Ken Gordon discussing systemic non-biologics or biologics with Dr. Alan Mentor in podcast number 36. Contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others who have psoriatic disease through our one-to-one program, which offers trained volunteers who have a connection to the disease. Reach out at education@psoriasis.org or call 800-723-9166, option 1. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comments. Thank you again to our sponsors, Bausch Health Foundation, Celgene, and Novartis for their support of today's webinar, along with others in the Psoriasis Guidelines webinar series. Finally, you can access our webcast archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for attending.